Hi everyone, I'm Kathy, one of the medicine residents, and this is my mentor, Dr. Moeller, one of the genius epileptologists. Today we're going to give you guys a little brief overview on inpatient seizure. Let's get started. First, we're going to start with a 5-minute bedside assessment, then move to diagnosis, treatment, assessment and plan, and then we'll end with some take-home points. Alright, so say you're overnights and the nurse calls you to say, I think the patient is having a seizure. What should you do? First, ask them to describe what they see. Is there unusual posturing? Is the head turning in one direction? These are things that have high likelihood ratios of helping you diagnose seizure. Also, as you're running down there, ask them to make sure to get vitals. Is the patient desatting? Are they hypertensive or hypotensive? Not only is this going to help you uncover what's going on, but it'll also help you decide where to triage the patient. Something that's very fast and very helpful is to get a finger stick. I've been to stroke codes before where the finger stick was 19 and that would make any person seize. Next, it's really helpful to check labs. Sometimes if you draw labs as soon as possible, then you can demonstrate and document in the chart a high anion gap metabolic acidosis with a high lactate. That is super helpful to just, have chart documentation of a seizure, besides just you and the nurse saying, seriously guys, they were shaking. Something that frequently comes up that you learn about in med school is prolactin. In my experience, this hasn't been too helpful because you need, a normal baseline to compare it to. But if this can be drawn kind of immediately in the post-ictal period and it's highly elevated, and then you have a normal one, say from the next day or even previously that's normal, that is something that could be helpful as a lab value that increases your suspicion for seizure. And then this is something that people don't give themselves enough credit for, but you can always do an exam. Some people might say if they're very altered, how are they going to have the patient cooperate with them to perform a neurological exam? And the secret is to be mean and apply some noxious stimuli. You want to know if there is focality to the exam. Remember, if there's some underlying mass in the brain, if there's a stroke that's causing the seizure, all these things are going to have some kind of focal exam. One side is going to be different from the other. Now, where should the patient go? If the seizure stops by itself and the patient is waking up, it's probably okay for them to stay on the floor. And on the complete opposite end, if the patient is desatting, you have to call anesthesia, you have to intubate them, then that patient's going to have to go to the ICU. Step down is a good gray zone if the patient is a little too sick for the floor, but not quite, having any ICU needs. All right, let's talk about differential. First, not everything that shakes is seizure. This is a great video of German medical students syncopizing and having shaking movements that look a lot like seizure.
If you bend down on your knees and hyperventilate for a minute or so, and then quickly stand up and valsalva as you stand, you will syncopize. So here's a healthy, normal German medical student syncopizing away. There he goes. He's taking a little longer than usual. There he goes. I want you to watch on each of these patients what their movements are like. So he's shaking. That's the myoclonus that reliably accompanies somebody who has transient ischemia to their cerebral cortex, or it may be the basal ganglia, we're not really sure. So she twitches a little bit. Those are fine examples. But you say, I can tell the difference. Well, you tell me if you can tell the difference between this guy. Watch this. Watch these movements. If you're seeing this yourself in the emergency department, I would argue this would be difficult to distinguish from a generalized tonic-clonic seizure, let alone if we're asking these patients' family members who are freaked out. Watch her. She's my this is a normal person. This is you. You can do this too tonight in your hotel room.
What are some other things that can look like seizure? Migraine with atypical aura, where you have headache with focal neurological signs. You can have TIAs where there's limb shaking. You can have sleep disorders that look a lot like seizures. Movement disorders can have a rhythmic tremor that look like seizure. And of course, the psychogenic non-epileptic spells or pseudoseizures. Studies have shown that based on history and exam alone, not even epileptologists can consistently distinguish what is seizure and what is not. You really need EEG to help you. Right. Let's take a super brief look at EEG. Similar to EKG, this uses electrodes on the body's surface to measure electrical activity that's inside the brain. This is an example of what EEGs might look like. This is the person's nose. The leads on the left are odd numbers, the leads on the right are even numbers, and you put this all together to get a screen that looks like this. So when you're reading EEG, you're scrolling to something that looks like this. There's pages and pages of squiggly lines, and it's really hard to know what you're trying to look for. If you mark something on the EEG like this, the EEG reader can jump right through it, and it makes it a lot easier to pinpoint. So basically, if you see something, press the button and describe what you're seeing. This really helps the person who's reviewing the EEG later. Now, let's go through some brief examples. You walk into the patient's room and you see this. What are these? Is this concerning? Or is this seizure? Actually, these are eye blinks. Basically, your eye is charged, and when you close your eye, it rolls up and creates a deflection that's seen on EEG. So this is okay. How about this? You walk into the room and you see something like this. This is concerning. You see it affects all the leads. This is a seizure. This is very concerning. How about something like this? So EEG is very complicated. It takes a fellowship to be able to read them. And that's because it's very difficult to distinguish things that are benign and things that are epileptogenic. So you might see this here, these basically checkerboard features that look like they're rhythmic and seen throughout the EEG. But this is actually chewing. Basically, these are your cheek muscles creating myogenic artifact, and this is okay. So let's break down the EEG report. First of all, if you see the actual word seizure, that's probably concerning. You might also see something called LRDA, which is lateralized rhythmic delta activity. This means the brain is not quite seizing, but it's thinking about it, so it's something of concern. Reassuring words are if there are no epileptogenic periodic discharges or no seizures. Also, something that we frequently see on our medicine EEGs is just kind of reflective of metabolic encephalopathy, generalized slowing. This means the brain is kind of off, but it's really not having excitability that's concerning for seizure. Let's talk a little bit about different etiologies. The most common cause for seizure in the elderly is actually stroke. Think about this if you have a patient with AFib whose anticoagulation is being held in the setting of surgery or bleed. Something else is if there's something underlying and irritating the brain, a tumor, an abscess, a vascular malformation. You can have a strange presentation with an encephalitis, infectious, autoimmune, paraneoplastic. You're going to probably need a lumbar puncture on these types of patients. If there is traumatic brain injury, for example, in the setting of a motor vehicle accident, or something that we see very frequently is a post-arrest patient who's being chilled and hooked up to EEG and goes into status. Alcohol withdrawal, something else we see frequently on the medicine floors. This usually causes a generalized tonic-clonic seizure and usually have some history of alcohol use. Less likely in our population, but something to not forget, is eclampsia in pregnant patients. As always, electrolyte abnormalities such as a sodium of 110, a super high pneumonia, some kind of strange ingestion. These are all things that can cause seizure. Febrile seizure we don't really see as much in adults, but as again a possibility. Something else that happens in inpatient seizure especially is someone with underlying known epilepsy who is just missing their medication, either because they are in PO for a procedure, if they're altered and they're not taking it consistently. This is also a common cause of seizure in the inpatient setting. So, what can we do to treat seizure? If you have a patient who's actively seizing away, this is the official evidence-based guideline for convulsive status. But let's break it down to the two most important parts, here and here. So what can we do to break the seizure, which is basically just your brain having too much electrical activity? Studies have shown again and again that benzodiazepines are the first agent that you need to give, and 4 milligrams has actually been shown to be better upfront than continuing pushes of 2 milligram, which may be what some of us learned in medical school. But of course, use your judgment. You also definitely need to stabilize the patient. Do you need to intubate them? Do you need airway control? Are they hypotensive? Just triage the patient as you normally would. While benzodiazepines will kind of break this initial seizure hyperactivity, you need another agent to kind of maintain calm long term. My favorite go-to is Keppra, one of the newer anti-epileptics. Most people tolerate a 2-gram load pretty well, and then based on their creatinine clearance and their age and things like that, you can start people on, say, 750 milligrams twice a day. Keppra is great because it's really well tolerated. It doesn't have a lot of the interactions that older anti-epileptics such as Depakote did. It doesn't have some of the dangers of loading that other agents had as well, such as phosphonatoin. So the only real side effect we see is sometimes it worsens behavioral disturbances and causes irritability. But in the acute setting, it's definitely a nice agent to go with. Next, you kind of want, if you haven't already, to get imaging. Are you worried about a bleed? You can just grab a head CT. Of course, MRI is going to be a much better picture, especially with contrast if the patient's kidneys can tolerate it. Unfortunately, very inconveniently, the MRI cannot be done if the patient has EEG leads on. So you're going to have to either hook them up to EEG or get the MRI. And of course, we need this really hallmark, benchmark pillar of epilepsy, which is EEG. Moving on to our assessment plan and write-up. Basically, you want to include what was seen, especially if there are factors that have high likelihood of being suggestive of seizures, such as a delay afterwards in return to baseline. When you have some time, you want to go back and ask if there are any additional risk factors, family history, recent brain trauma, things that might have provoked this. Of course, the exam is very important, especially if there is focality. Everyone does the hold my hand, squeeze my fingers, push and pull exam, but I find things that are more subtle can be more helpful, such as looking for pronator drift, fine finger movements, and things that other people don't check, such as reflexes. These are going to be helpful for you in distinguishing if there is one-sidedness to their exam. Of course, as mentioned previously, getting lab data to sort of document the presence of an actual seizure, and then EEG data is really going to help you cinch your diagnosis. Imaging, as also mentioned, is going to be very helpful and should make a big part of your assessment and plan. Your differential as to 1, whether this was actually seizure or a mimicker, and 2, if you're convinced that this is a seizure, what you think is the underlying cause for it. Then you can talk about what additional workup you would like to do. Does the patient need more imaging, more EEG? Do they need a long-term video EEG admission to characterize what's going on? And then the treatments that you would like to do. In addition to kind of correcting any underlying metabolic abnormalities or brain lesions, there are a wide range of AEDs that you can use, and you can have them follow up in seizure clinic to discuss this. Let's review some take-home points. I want to emphasize the importance of video EEG in diagnosing seizure. We reviewed some differential and seizure mimickers and the acute treatment. Basically, Ativan and Keppra are your friends. Otherwise, I think it's important here to mention some additional notes, such as who really needs long-term therapy. If the seizure was provoked, they might not need to be on long-term therapy. This is hard sometimes to answer in the acute inpatient setting, so I find that referring patients to, we actually have a first seizure clinic to specifically look at these cases is helpful. The laws of driving after a seizure are variable from state to state. In Connecticut, there's no real set timeline, but we usually recommend not driving for at least 3 to 6 months just in case, and this usually gives the patient time to follow up in epilepsy clinic and they can discuss further how long a duration they think is necessary. Also, just some common sense. You should advise your patients not to swim alone, not to climb ladders, things like that where a seizure could be potentially fatal. Here are some resources you might find useful. As always, UpToDate is Word. I also found this hospital onset seizure paper helpful. So thank you all so much for watching. Thank you to Dr. Moeller for helping me put this together, and good luck.